off these different substances. So I would like to please welcome AdventHealth's Ocala's Lung Health Navigator and Radiology Associates Medical Director and Chief of Radiology, who will be speaking about the prevalence of lung cancer and the importance of screenings.
Thank you, Sarah, for that very informative presentation. I know we all learned a lot about thinking, and we can all learn more about thinking. Alright, so we're just going to do a quick devotion. Cancer cannot cripple love. It cannot shatter hope. It cannot corrode faith. It cannot destroy peace. It cannot kill friendship. It cannot suppress memories. It cannot invade the soul. It cannot steal eternal life. It cannot conquer the spirit. My health may fail and my spirit may grow weak, but God remains the strength of my heart. He is mine forever. Can anyone tell me what the top 3 most common types of cancer are in the United States?
Lung, breast, colon.
Colon, breast,
Lung.
skin.
Lung.
So breast is number 1, and number 2 is lung, and number 3 is prostate. And can anyone tell me what the top 3 most common types of cancer are in the state of Florida? Lung, colon,
Breast. Breast.
Lung is number 1, breast cancer is number 2, and melanoma is number 3. Florida, Sunshine State. Alright, so here is the Marion County demographic for the melanoma rate. And it is a little bit higher in males than in females. And in breast cancer, it is higher, significantly higher in females than in males, but it still does occur in males. And it is higher in Marion County compared to every other county in Florida. Now, lung cancer is categorized with tracheal, bronchus, and lung cancer. And if you look, Marion County, Sumter County is the county that has the highest amount of lung cancer cases in the entire state of Florida. Villages, things like that, we have the highest amount. And the male population is significantly higher than the female population, but the female population is actually higher with the lung cancer than it is the breast cancer. So it is significantly a huge problem in not only our county, but also the state of Florida as well. So this slide is a little bit busy, but in 2016, we had over 685,000 people that died from lung cancer worldwide. And in 1990, there were only 516,000. And then if you look at this chart over here, so in 2016 in males, there were over 105,000 males who died from lung cancer. And then in females, 85,000 died from lung cancer. And then half died from breast cancer, but still, lung cancer is not only the most common type of cancer in Florida, but it is also the #1 killer of all cancers, not only statewide, nationwide, and worldwide as well. So on that note, I would love to introduce our physician speaker, Dr. John Scales, who is our Medical Director, Chief of Radiology at AdventHealth Ocala, and also Radiology Associates of Ocala. He is board certified diagnostic radiologist and specializes in vascular and interventional radiology, and he is also our Vice President of our longitudinal board at AdventHealth Ocala.
Congratulations, everybody. You've eaten lunch and made it to the 3rd portion of our presentation. Feel free to stretch. I know everybody's kind of tired. But I'm going to be talking about low-dose lung CT screens. Should be a quick jog through a very kind of complex thing. And I'm going to give you kind of how we got to where we're at now today. So how do we perform low-dose CT lung screening? And why are we doing it? So take a look at this image on the left. See the nice American flag. Go down, you'll see the Italian flag, a bunch of flags from different countries around the world. In the United States, obviously we like to go big and better. So back in 2011, CMS and the UPSTF, which is United Preventative Task Force, said, hey, we've got a problem with lung cancer in this country. Really the way we were looking and finding lung cancer is going to your clinician saying, hey, I'm a smoker, I've had this cough, and it's nagging. Or going to the ER and saying, hey, I've got a cough, and then doing a chest x-ray. Chest x-ray is basically a shadow, right? Multiple shadows on each other. You see the heart, you see bony landmarks, you see the lungs, which have a lot of air in them, obviously, because you've got small cellular lining, which, as we just learned, doesn't like to have anything put in it. So that's why smoking and vaping are horrible. But that's what we were using for screening. I mean, there are a lot of things on this chest x-ray where you can really see a small nodule, right? So the NLST, National Lung Screening Task Force, got cases of low-dose CT. And by low-dose CT, I mean CTs that are not at a diagnostic level. So we reduce the radiation amount you're getting. So it's about 14 times the dose of an x-ray. I'll have a chart coming up. Still very low dose. The lungs are a nice organ because there is so much air that anything that's a soft tissue nodule or a little nodule we can see very clearly, okay? So they said, we're gonna take chest x-rays. Go ahead. I'm going to show you. Just wait. I promise to show you. I like to talk. I apologize. So I'm going to show you all that and show you kind of how that looks. A couple more slides. All right. Don't pee your pants. It's coming. But anyways, they took 53,000 patients, okay? Male, female, 55 to 74, and said, well, let's compare chest x-rays to low-dose CT head-to-head. And we're going to see in these patients who've been smoking what we can do and see if we can effectively screen these patients much sooner than finding the patient with the stage 4 cancer that's metastasized everywhere and they have little hope of survival. So that's what they did. And if you go over to the far right corner, this is kind of the impactful thing you need to take. This is the take home, okay? Stage 1 cancers. That is a small cancer. That means it hasn't gone to lymph nodes, it hasn't gone to other organs in the body, there's no metastasis. That's where we want to catch every type of cancer we find, okay? Even better if it's a pre-cancer, but stage 1 is what we want to catch. Breast cancer and lung cancer, you name every type of cancer, that's where we want to find it, okay? So 63% are found to be stage 1. That doesn't mean out of 53,000, that's just the stage 1s that we found, okay? Mortality reduction. So that means in the people who had diagnosed lung cancer, 20% had a reduction in mortality. That's 1 in 5 people diagnosed with lung cancer. That's pretty powerful, okay? So that's how we got to this stage. They kind of confirmed all this data in 2013, and then, you know, there's the whole, we've got to make sure we can pay for this, who's going to be the right person to be in this type of screening. So here you go, here's your slide. Multislice CT. It's cutting up, not physically, but cutting you into slices with a scanner, okay? As opposed to a chest x-ray, which is just a projection of a 3-dimensional object on a 2-dimensional plane, we're getting slices. So here's a CT, here's a small nodule, okay? That probably measures about 3 millimeters, 4 millimeters in size. That's what we want to catch. And this type of program at low-dose CT, if you qualify, you're getting this CT every single year if it's a low-risk lesion. And then if not, maybe we say in 6 months, we'll look at it again, make sure it hasn't changed at all, anything that's concerning. And if we catch a cancer that's larger or a nodule that's larger and say, hey, we think we better take another look at this with a different modality, we will. PET CT imaging comes into play. biopsy potentially. So there's a lot of different avenues to kind of catch these things before they get out of the box and become very dangerous cancers. So this is what I was talking about, radiation dose. If you go on a trip, get some radiation, just going up into the air about 30,000 feet, 10 hours. You get a chest x-ray, you're getting some radiation. You get a mammogram, 0.4 millisieverts. Your average background radiation, which I'm getting some right now, you're getting some right now, we're all getting some, is about 3 to 5 millisieverts. So this is less than your annual background radiation if you're getting one of these tests. And then a diagnostic CT, depending on where you're doing it, can give you 7 millisieverts. And sometimes we have to progress to that, okay? If we find something and we need to do a diagnostic CT, but that's case by case. So again, why is early detection important? 8 million Americans qualified for this type of screening. Really, what I'm here to talk to you guys about today is obviously low-dose CT lung screening, but we get to empower the rest of the community, just like I'm doing to you, to help educate people, because right now that's the biggest thing. Educating people who qualify for this to get it done. Because I'm sure all of you in here know more people who've smoked in their lives rather than vaping, not to take away from the message that was being told before. I mean, how many people know somebody who's smoked? How many people know somebody's had lung cancer? A large majority of this room. So that's why it's important for any of your friends, family members, who need to know about this, okay? So how are the scans interpreted? Sorry, this is a small slide, but we use a system called lung Rads. Okay, Rads is just an acronym for, sorry, I'm blanking on it, but it's basically taking the data and compiling it so that it's cohesive and everybody in the healthcare team knows what we're talking about. I know if I hand this off to a radiologist in a year who's going to be reading a CT lung screening, that they're going to say, use the same type of language. It kind of piggybacks off of what we do in mammography, which we've been doing for a long time, and takes a lot of concepts from that. So the vast majority of the low-dose CTs that I've done, and we've been doing it for about 3 years now, 3 or 4 years, fall into this category, 1 through 3. That's nice because on to the right, your chance of malignancy in the 1 through 3 category is about 2% at the highest, okay? And then when we get into 4, A, B, and X, those chances rise up a little bit, and that's when we want to start the conversation of, should we do some other diagnostic testing? Should we do a biopsy, et cetera, et cetera. But I'd say the vast majority of these lung screenings that we do fall into this, which it could still be a cancer and it grows. We're catching something over time and we want to watch it, okay? But when we're concerned about something, they fall into this category. We can still watch it, but we're going to watch it a little bit closer. So this is a slide talking about the Lung Cancer Alliance lung screening standards. I'm not going to say all this. Please take the time to read for 10 seconds. Any questions about anything on the screen or anything that I've said? Okay, we're going to keep going. So we started 2016. We screened over 650 patients. Like I said, the vast majority are 1 to 3 categories there. Put this picture of a climber, that's not me. I would never do something like that. 1, because I'm not athletic enough, but 2, because we've got a long way to go. I mean, we have to work to get there. And like I said, education is the biggest component of this, even though we're putting a lot of structures in place to help kind of increase this program. So who are the interested parties in low-dose CT? Ma'am, do you mind answering that question?
Somebody who knows smokes.
Exactly. We're all the interested parties, okay? We have friends and family. Half the room, more than half the room, just raised their hand, said, you know, somebody with lung cancer. It's going to affect somebody you know, friends, family. We all have to do our part to educate and let people be aware, okay? How do we increase utilization? We have days like this where I'm talking to you, We have tumor boards. I talk to practitioners, you know, first line people, PCPs, patients themselves. This is all important. So what do I do to order or initiate this testing for myself? Anybody have any clue? Exactly, okay? I can't, as a radiologist, if you said, oh, I want to come talk to Dr. Scales, how do I get this done? Or could you order for me? I can't do that, okay? But your primary care physician can definitely do that. If you qualify for this, you know, the age ranges, this is where we do it. This is our offices. I work with Radiology Associates. We're joint ventured with AdventHealth, so it's AdventHealth and our office doing that. This is just to show you on a map if you're not familiar with us. But you just need to qualify, and then you can have it done. And like I said, it's not a one-time thing. It's a screening process. So if you're 50 years old and you have a 30-pack year smoking history, and you also say, I'm okay with getting treatment if I do have lung cancer, you qualify every year until you're about 70. You're going to get a screening low-dose CT examination. All right? So this is
Define pack year.
pack year. Okay, so if you said, I've been smoking for a year and I smoke 30 packs a day, that's a 30-pack year history. Nobody could really do that, I hope. But that's what pack year means. So you could do 2 packs a day, which is, I guess, reasonable for a smoker. I don't know, I've never been a smoker, but for 15 years, and that becomes 30-pack year history. So it's simple math. I mean, if you did half and you did it for 60 years, that would be 30-pack year history. So I apologize using vernacular without kind of explaining it. That's what it means. Okay? Any other questions regarding to qualification? We're going to have forms in the back so you can see, take to any family members, friends, let them know what those are. So here's kind of all of our numbers for everything we've done. We've only had about 600, maybe more, of low-dose CT screenings that we've done. Everybody's going to get a follow-up, okay? Remember, even if you're a 1, you're going to get a follow-up because you still have the smoking history. And if we do a low-dose CT and you have no nodules, that is great news, but you're still at risk for developing. Okay, so we got to keep the screening going, just like mammograms or mammography. I don't have the numbers up here of all the 4As to 4Xs we've had. They've been very few, but we also need to increase kind of the capture rate or the number that we're doing. So, are you eligible for cancer screening? Laura, this is in the back, is that correct?
In your bag.
It's in your bags, okay. So, just look at this. Really, what I've said, 55 to 74. So apologize for saying 50 to 70. But these are all the questions that need to be kind of check marked to say you qualify for this, okay?
And to touch on that, and if the kids are a little bit younger, or you have like secondhand smoke exposure, asbestos exposure as well, your primary care that you want to discern as to if you are eligible. This is like your CMS Medicare qualification.
Any questions about low-dose CT lung screening before I talk about the CDC, kind of right on the coattails of our previous presenter?
How thin are your slices?
How thin are our slices? So,
In other words, what I'm asking, could there be a nodule between the slices that you didn't catch?
there could, that's a great question. Our slices, I'd have to look this up. I think they're 3 millimeters or 2 millimeters. I'd have to check that out, but that is a very, very thin slice, okay? 5 millimeters, you could potentially miss a nodule that's 2 millimeters in between those slices. But we also, I mean, when I read these, we're catching nodules that are 2 millimeters or 3 millimeters. That's very, very small. And number 2, a vast majority of these nodules turn out to be nothing that we track, okay? But it's important because small nodules could always begin very small, turn into something horrible. And we also have to discern, is it a solid nodule? Is it what we call ground glass? There's a lot of different components that go into it. But I think, and I have to.
I think they're 1.5 or 2.
Okay, yeah, I think it's either 2 or 1.5, very thin, very thin. So the likelihood of missing something It would have to be very minute in size to miss something. Any other questions about low-dose CT that I can expound upon? We've kind of rushed through this. I apologize.
Are insurances covering this?
They do. They do. Okay, Medicare covers this. Because if you catch these cancers early, the morbidity, mortality, and cost savings that come into this, beside, if you catch a stage 4 that's metastasized everywhere, you've got radiation treatment, chemotherapy, a lot of things that are very costly. If you catch it at stage 1, it can involve small surgical procedure, removing a portion of the lung, it's gone, okay? So they do cover it.
If you meet
You
the
have
criteria.
to fall in that criteria. You can't just say, hey, Dr. Scales talked about low-dose lung screening. I've lived around a guy who smoked, or, it depends on what your primary care physician says, but there's criteria that you have to meet in order for insurance companies, payers to pay for this, okay?
And sometimes too, I think it's a matter of educating your primary care, that may come to this brochure and show them, sort of these are the guidelines, and this directed in this category. The guidelines just changed 2 years ago?
I think they updated them in May of 2019, so, not the guidelines, just the lung Rads. There's data constantly coming in. What I was showing you with the 53,000 patients, that was in 2013 when that data came out. So now we're adding more people. If you're getting screened, you're going into a registry and we're looking at more data. So it is empowering what we're doing, kind of guiding how we help patients and who gets to be screened.
One of the criteria is that the patients have to be asymptomatic. You can't really have any symptoms, so weight loss, any symptoms that would possibly mean that you've got cancer. No sudden onset of cough or change in cough, coughing up blood, hemoptysis, anything like that. You can't have anything like that going on. Obviously, you're gonna have a chronic cough if you've been a long-term smoker, and that's understandable. We expect that. You may have COPD and things like that, but anything that's new onset, you can't have. In that case, we would do a CT of the chest instead of a low-dose lung cancer screening.
That's correct. And this is Amanda. She works through RAO. She's not just somebody who stumbled in here and started talking. So she knows what she's talking about. Yeah. So, any more questions on that? I know that, again, that was quick, but the basis is we're all stakeholders, and we all should be pushing for this, not pushing for it, but talking to people who smoke. Because I think, one of the worst things is, as human beings, we say it's never going to happen to us, right? That's just kind of the way we are. You really need to kind of take care of yourself, do things that are right, and this is much more empowering than a chest X-ray. CT's only been around for 60 years, and we've only really gotten good at it in the past 20 years. So this is a real nice tool in our toolbox to help fight against cancer, and we're only in the first few steps. Okay? So now I'm just going to talk about a little bit about vaping from the clinical side. Kind of